Report to computer. There. All right, since this is a new recording, welcome to GI drugs. It is July 13, I think, July 13th. We're going to talk about GI drugs. And here we go. If you guys don't know what PONV is, it was in the email, post-op nausea and vomiting. Where's my thing? Here's a review of the GI system. We're not doing that. If you want to review the GI system, go back to your anatomy book. I want to talk about some drugs. We eat the food, it goes down to the belly, it gets digested, you take the nutrients out of it, it goes down to the anus, you're sitting on the pot, it comes out. It's a cycle of life. All right, we are going to talk about this though. Major activities. Is somebody late? Oh, you're welcome. Major activities. I guess the person who got the 2 extra points just thanked me. You're welcome. I should do it for all of them. I need to do that after this. Activities of the GI system. Secretions of enzymes, acids, bicarbs, mucus, food absorption, digestion of these foods, motility, which brings the food down to our anus to the toilet bowl. There's medicine for that. For some people, it doesn't work. And it is your job as a nurse to help these people. If you don't know what to do, look on the PRN list of the MAR. There's MAR there for constipation. They use this type of laxative, use this light, medium, and heavy duty. So we're going to go over all that. There's different types of secretions in the GI tract. Saliva, mucus, digestive enzymes, sodium bicarb, pancreatic enzymes, bile, and endocrine hormones. What's more applicable to us is the saliva, the mucus, digestive enzymes, sodium bicarb, pancreatic enzymes, bile, because people throw that up. Not much for the endocrine hormones. Stop. I already said you're welcome. Let's talk about digestion. Digestion. It is the process of breaking food into usable, absorbable nutrients. And after the food is digested, we absorb it. The food goes through the intestines. The nutrients are removed from all this stuff, and it goes into our bloodstream, the protein, the fat, potassium, sodium, everything else. That's how we absorb it. And then when we're done extracting all the stuff that's in the food, our GI system pushes it down through the GI system, down to the lower GI tract, to the anus, into the toilet bowl. That's when we poop it out. And there's this thing called GI motility. Because when we eat food, it doesn't just drop down into our belly. There's this thing, it's peristalsis, that kind of keeps the food moving. And one of the medications we're going to talk about later is to help with this, to push the food down. Because if not, they're going to be miserable. I'm sure you've been constipated before and food it was stuck there and it's miserable. There's also some reflexes that we need to talk about. One of them is the esophageal sphincter. Oh no, that's not the reflex. Gastroenteric reflex. The what's the other one? Swallowing reflex and the vomiting reflex. We'll talk about that some more in a few minutes. So our job is to maintain homeostasis of the GI tract. because overstimulation of the GI tract causes constipation, and overstimulation causes diarrhea. And we can fix both. It's easy. Underlying causes of the GI disorders: dietary excess, buffet kingdom here in Vegas, stress, hiatal hernia, esophageal reflux, adverse drug effects. Two of them here are related to Vegas, and peptic ulcer disease. All right, let's talk about drugs. Drugs affecting the GI secretions. So how does it work? They work in different ways. Decrease GI secretions activity. They block the action of the secretions, protect the coverings, the lining of the GI from secretions, replace missing enzymes. Oops. And two of the main culprit for these medications are GERD and PUD. A lot of our patients in the hospital, especially with the extensive medical history, you go, this is my 78-year-old patient. He has COPD, Alzheimer, blah, 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 GERD. It's almost common for the elderlies. I may have it. So what's GERD? When we swallow food, there's your gastric juices on the screen. It's just waiting for food to process the food in the stomach. There comes the food, the bolus, the chyme. It's processing it. It's working it. It's digesting it. It's processing that food. But sometimes this esophageal sphincter that seals those gastric juices, it doesn't work as well. So now all this gastric juices is starting to come up the esophagus. And when it does, there's that gastroesophageal reflux or GERD. It's kind of bad because all that gastric juices is now messing with the lining of the esophagus. And not only that, if it gets too bad, if it gets all the way up, and now we have some gastric juices, we may be aspirating. Let's imagine if you're aspirating these gastric juices. Gastric juices in the lungs equals bad news. Next is the peptic ulcer disease. This one is when you have erosions in the lining of the stomach. It hurts. It's painful, often occurring with meals. One cause of this is the H. pylori bacteria in the belly. So with GERD and PUD, peptic ulcer disease, there's 5 drugs. H2 antagonist, antacids, PPI, which is mainly what we give our patients in the hospital, GI protectants, and prostaglandins. Let's break it down one at a time. H2 antagonists include, H2 antagonists. It turns down the volume of acid production in the belly, in the stomach. They are your tidine drugs: cimetidine, ranitidine, famotidine, nizatidine. Never heard of the last one, but you have, I think, the number 2 and number 3, Zantac and Pepcid, are commonly used in the hospital. I don't know about Tagamet. Maybe, I know I see it a lot at CVS or Walgreens. There you are.
Did they take away Zantac?
No, they still use it.
Even though it can give you cancer?
Nope, it's still there. It's still on our formulary.
Good to know.
It gives you cancer. I didn't know it gives you cancer.
Yeah, there's a big lawsuit about it right now. They took it off the shelves.
Oh, why are we, maybe I have to ask our pharmacist, see if it's still carried in our formulary. If that's the case, if they took it off.
It works really well, but yeah, they're saying it causes cancer.
Okay. Because sometimes we use Zantac, Pepcid. We like Pepcid because it comes in IV form. I'll talk to our pharmacy, Dr. Chin, pharmacist, I mean. Or if you can talk to a pharmacist, you can ask him yourself and let us know. Actually, I'll be in the hospital tomorrow, so I can ask him. H2 antagonist selectively blocks H2 receptor sites, leads to reduction in gastric acid secretions. What do we use it for? Short-term treatment of active duodenal ulcer, or now I'm saying cancer, or benign gastric ulcer. I guess I didn't know this. This is not going to be on the test because I'm just finding this out. They took it off the market. So for cancer. It's also used for the treatment of hypersecretory conditions such as Zollinger-Ellison syndrome. Other uses for this are prophylaxis for stress-induced ulcers and upper GI bleeding in critical patients. This is why when we're giving these patients, this is for your stress, to prevent stress ulcers while you're here in the hospital. You may or may not be on this thing when you get discharged. Treatment of gastroesophageal reflux and relief of symptoms of heartburn, acid indigestion, and sour stomach. One good thing about this H2 antagonist is that it's readily absorbed after oral administration. It works right away. It works great. The rest of the stuff there metabolizes in the liver, excreted in the urine, are generic for most, if not all, of the GI medications. So I'm not even going to mention that next time. Contraindications, I'm going to stop mentioning this too. With any medications, it's allergy. Of course, we're not going to give somebody something that they're allergic to. Caution with these medications: pregnancy, lactation, hepatic renal dysfunction. It has GI effects, CNS effects, cardiac arrhythmias, and hypotension, which I have not seen any of these effects on the patient. But it can happen.
That actually, this drug specifically has a really weird side effect, and it's kind of rare, but for the GI effects, I just had to bring this up. I was taking it for a ulcer, and it literally caused my body to be allergic to all foods because I was on it for a prolonged period of time. It literally caused me to be allergic to everything, and like wheat, corn, soy, potatoes, tomatoes, I mean, you name it. And the doctor said that it was a hypersensitivity that was caused because of the H2 inhibitor. I don't know. It's a weird side effect. So you might, I don't know, just want to note that that's a weird side effect, but it happens. And he said it happens often and usually in adults.
Cool. Yeah, never heard that before, but hey, this is a first-hand experience. Thank you for sharing. Did you have you didn't have cardiac issues with it? I hope not.
No, I didn't. Just those GI issues. But I mean, it went away. The allergies went away after a while. But yeah, it made me allergic to everything. It took 2 years for it to go away.
It could be related to this slide that's on the screen now because it interacts with, it looks like all of the medications: blood thinner, what is this, heart medicines, alcohol, breathing medicine, what else is on there? Psych medicines or mood medicines, blood pressure medicines there. It's a lot. So it may be related to this. I don't know what you were on, but yeah.
You could be right. I was taking benzos.
I could be right. I know I'm not. I'm just kidding. Man, because I don't know. That's why, especially with the cardiac issues, a lot of these patients are they consult the cardiologist. So because of the drug interaction. Let's see, what you need to know for these H2 antagonists as a nurse. Let me look at this list. HMP standard, standard impaired renal or hepatic function because it metabolizes in the liver, excreted in the kidneys. Skin, pregnancy, lactation, neurological status. I guess it's there. It happens. Doesn't happen often. Cardiopulmonary status. Look at this one, including pulse, blood pressure. I guess it's something we monitor, but we don't really need your pulse and blood pressure to administer this medication. There's no hard stop. There's no parameters. It's just something we monitor. And appropriate lab values. We'll get to that in a few minutes. Here's the drug card. There's not much information here aside that it works. If we use the IV in a hospital setting, we like to use the IV version because it works right away. That goes with any other drug. Next is the antacids. The goal for antacids is to protect the stomach from its own acid. Look at all these acids, and there might be some ulcers in the stomach that we need to protect the stomach from. So this is what we use it for. There's a mnemonic for antacids. Let's see if you can figure it out. Sodium bicarb, calcium carbonate, Tums, aluminum salts, and magnesium salts, or milk of mag. I wrote it up here on a side note. Milk of mag is also used as a laxative. You might see that on a PRN listing of your patient next time you're in the hospital. How does it work? It immediately neutralizes the stomach acid. It works immediately, fast. So if you're having some stomach issues, it's upset stomach, take it, what is it? Tums, and it works. I have a jug up here in my pantry. Symptomatic relief of upset stomach associated with hyperacidity, as well as, that's delete, that's nothing, that's a duplicate. Contraindications, nothing there, same. Caution, any condition that be exacerbated by electrolyte imbalance, GI obstruction. Why am I talking about electrolyte imbalance with this antacid? Because of this adverse effect. It messes with the magnesium, the calcium, the phos. So you can see how someone's electrolyte can be thrown off by taking some Tums. I mean, it's not gonna be way off if you take Tums a couple of times, but if you're taking it long term, I know some people, at least I've seen it on TV, they're just popping on the Tums because they have chronic indigestion or hyperacidity. So those guys probably need to come in and get their blood levels checked. Drug interactions, if there's a lot, so it's too many to list, and that's why I said earlier, a lot of the cardiac patients have to consult with their cardiologist if their primary care physician prescribed them some Tums or anything. They cannot just go to CVS or Walgreens and get something. It has to be approved by the cardiologist. No, do not mix this with any other drugs because of this. Do not take with any other meds. It does not last long. Oh, it's not on this one. Oh, it's on this one right here. If you have to take antacids with your with your medications, please take it 1 hour before or after the medicines. As you saw from the previous slides, it doesn't stay in the system in your stomach long. So you should have enough time for this thing to get out of the system for you to take your medications. If not, it will lower the efficacy of whatever medications you're taking. not for heart failure. Talked about this already. Nothing over the counter is for heart failure. Not much there. Next is PPI, the prazole drugs. You have administered probably half of this in a hospital setting from the, if not from home, what do we use in the hospital? Protonics. We use Prilosec, Nexium, depending on the hospital you're in. The last two I have not seen, Cabidex, Acifex, but the top four, definitely either over the counter or the 3 and 4 are in hospital. Especially the Protonics, because that also comes in an IV form. So if the patient needs a PPI, we can inject it through the IV. It works by reducing acid, by inhibiting the proton pump inhibitor, inhibiting the proton pump in the parietal cells of the stomach. Indications: heartburn, GERD, ulcer prophylaxis, which is why we are giving it to our patients in the hospital. Prevention of stress ulcers while you are in the hospital. You will get that. Patients will ask you that. What is this Protonics thing? What is this Pepsid thing? I don't need it. I don't have indigestion. Oh, it's for prevention of stress ulcers while you're in the hospital, because all these things that are happening, all these medications we're giving you, it's you need it. Take it. Next, erosive esophagitis, benign active gastric disease, and long-term treatment of hypersecretory conditions. PPI acid is labile, rapidly absorbed in the GI tract, same liver and urine. There's not much contraindications or cautions for this. Generic stuff, pregnancy, lactation, definitely allergies. If you haven't administered this in a hospital settings yet, it's when you have to dilute. It's going to come just like that with a white powder in the bottom. Dilute and administer over 2 minutes. IV, slow IV push. Adverse effect. Let's look at this adverse effect. CNS, we don't see that as much. Dizziness, headache. I don't even know what asthenia is. Probably a typo I typed. Vertigo, insomnia. We don't see these things as much. The GI, diarrhea, abdominal pain, that maybe, but tongue atrophy, not as much, but I guess it's listed on there for a reason. Upper GI tract symptoms, also not much here. Epistaxis, no, there's no bleeding or anything with this. However, they have a drug interactions with a couple of these medications. There's a list of medications on your screen, but what I'm concerned about is the warfarin, the Coumadin, my theophylline, my blood thinner, and my breathing medicine. Are you trying to tell me if you give me this Protonics deal that it's going to affect my coagulation? That can be dangerous. You're trying to tell me if you give me this thing, this PPI, it may affect the efficacy of my breathing medicine. I kind of need my breathing medicine. I'm a COPDer. You cannot mess with my breathing. I can barely breathe to begin with, and now you're going to mess with my breathing. No, hard pass. They need something else. And Plavix, same as Coumadin, Plavix. What do you need to know? Right there. Why the first few lines are generic, just like with any other medications. The patient's going to ask you, why am I on this? I said this already. I don't take this at home. So you should be able to tell them why they are taking this PPI. And when you are explaining this to the patient, you're explaining it to them at a second grade level because they're not going to know. They don't understand our lingo, and they're going to get more confused if you do. Need regular bone density tests because long-term use of this can make their bones brittle. Possible C. diff on this one. Take 30 minutes before meals, although they're supposed to take it 30 minutes before meals, but in a hospital setting, it doesn't really work like that because of the schedule. Sometimes we're late giving the medicine and we just kind of bunch them all up together. Take 30 minutes before meals, ideally. If not, it's okay too for most patients. There's your PPI drug card. I don't focus much on the drug card. I think the only drug card I used was the insulin because it lists my long-acting to short-acting. Next, let's talk about GI protectants. They coat any injured area of the stomach to prevent further injury from acid. It is given to treat and prevent both stomach and duodenum or duodenal ulcers in the small intestines. Sucralfate, carafate. So if there's it forms a thick layer covering that overly exaggerated hole in the stomach. Promotes ulcer healing, rapidly absorbs. So when these patients take this carafate, it kind of soothes the burning pain in their stomach. It's as I explained earlier, this is like giving them Dilaudid or morphine. Their stomach just starts feeling well almost instantly because of that coating. GI effects of this, constipation, diarrhea, nausea, indigestion, gastric discomfort, dry mouth, dizziness, sleepiness. We don't see very much of these side effects with our patients, but it's there. It happens. It's like what Julie was saying. It rarely happens, but it does. Interactions with aluminum salts, phenytoin, and some antibiotics there. What do you need to know about this antipeptic agent? Take on an empty stomach. If you haven't figured it out yet, all of these medications I've been talking about so far cannot be mixed with any other drugs because it provides a coating. And I cannot coat my stomach and I cannot give my stomach a lining and then take something else. Then whatever I took, just kind of nothing happens to it. Or maybe I might get 50% of the efficacy of the medications. Do not take with any other meds. Bowel sounds. I need bowel sounds before I can give my patients some GI medications. Respiratory status. Well, we don't really check respiratory status if I'm giving somebody Protonics, Pepcid, or anything else. But it's there. Can I take other meds with antacids? I've said this many times already. No, 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 no. 1 hour before or 1 hour after. Probably see this question in a storyline format. Probably go with Nurse Samantha went to the strip, had a good time, blah, 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 blah. Now she wants to take antacids and her levothyroxine or something like that. Next, prostaglandins. Protect the stomach lining. All of the medications so far, it's used to protect the stomach. It gives it a lining. They work differently, having different chemical parts, parts. But in this one, inhibits gastric acid secretions, increases bicarbs, and this is a special one. Prevention of NSAIDs-induced gastric ulcers, treatment of duodenal ulcers, What's so special about this medication? You know, I'm going to test you on this drug, this prostaglandin, because I'm already telling you that it's a special drug. The previous 4 medications I talked about, Protonics, Pepcid, Carafate, they give the stomach a coating so it doesn't burn. It prevents, it gives them a soothing sensation from their GI issues. But this one, this is a special because it can also be used to induce labor. It works by softening the cervix and causing uterine contractions, leading to the expulsion of its contents or the baby. So, cautions, lactating women, and look at the effects. GU, it's not a GU effects, but miscarriages, excessive bleeding, spotting, cramping, hypermenorrhea, dysmenorrhea, and other menstrual disorders. This is a no-no for pregnant lactating women. Use something else. There's 4 other classifications that they can use, but not this one. This is not for them. So to assess generic information here, except the pregnancy and lactation. If they are, then they need something else. Next is digestive enzymes. There's 2. One is fake spit, fake saliva, and the other one is a fake gastric enzymes, pancrelipase, or what is it? Saliva substitute. Saliva substitute, it contains electrolytes and other chemicals and act as thickening agents to be used for dry mouth conditions. Next is the pancreatic enzymes. It's replacement enzymes that help with the digestion and absorption of the fats, proteins, and carbs inside the stomach. Contraindications, allergies there, but for the saliva, saliva replacement, watch out for CHF, hypertension, renal failure. I think renal failure is kind of pushing it too far, but definitely CHF, because it's going to, remember with the CHF, fluid. Most of your CHF patients will be on fluid restrictions. I want to control every ounce of fluid going into your system. So if I give you this thing, I'm introducing more, you're going to make more saliva, and that I know you're going to swallow the saliva. So I'm going to be introducing more fluids into your system. It may or may not be much, but in extreme cases, I want full control every single drop of fluid into your system, and I will lose control of that if I give you this. Pancreatic enzyme, pregnancy, and lactations, watch out for those in those patients. Adverse effect for the fake saliva, it's going to mess with my electrolyte levels, especially once I start intaking fluid from the spit, and just need to watch it. Get my blood drawn, Q day. GI irritations for the pancreatic enzymes. What do you need to know about these digestive enzymes as a nurse? That heart failure for the fake saliva. Everything else is about the same. Lab values. Not much there for the card. All right, let's talk about GI motility. I want to move some poop. I'm constipated. I got to move my poop. No, coffee helps, but I need some help moving this poop through my GI tract down to the anus into the toilet bowl. If not, it's gonna get backed up, clogged. And when I start talking about clog, it's bowel obstruction. How can we fix bowel obstruction? Surgery. We have to open you up. So let's talk about laxatives. Metoclopramide. I cannot pronounce that. I just know how to pronounce it as Reglan. Lactulose, mag citrate. Stop. Mag citrate, mag sulfate, docusate, mineral oil. There's 3 types of laxatives that you need to know about. One is the chemical stimulants, chemically irritate the lining of the GI tract. It sounds harsh, but this irritation causes the peristalsis, causes the GI tract to kind of, oh, you're pissing me off. I'm going to move. So poop, shoot, kind of shoots down. Bulk stimulants causes the fecal matter to increase in bulk, causing fluid to be released inside the GI tract and making them flow better. You might be thinking the opposite. The bulk, it makes them bulky, they get stuck. No, actually it doesn't, they don't get bulky like this. It's kind of just a little bit of bulk, which releases the kind of like a lubrication. And the next one, lubricants. We're gonna take this and it helps the poop kind of slide down to the lower GI tract. We want these medications for our patient because we don't want them to strain. It helps them poop, but in a hospital setting, especially in the post-op setting, I don't want my patient to be straining because they might mess up their surgical site. Boom, I just busted out my sutures or staples inside my stomach because I was straining. So I don't want that. So with the chemical stimulants, begin working at the beginning of the small intestines, and it pretty much works throughout because it's because of the irritation, it kind of pushes the poop all the way down. And the chemical stimulants cause the irritation. Now we talked about this already. Contraindications for this are heart blocks, acute abdominal disorders. This is a common theme. Remember this part. All the stimulants, I mean, not all the laxatives and antidiarrheal medications, acute abdominal disorders is a contraindications for all of them. Because you're not going to give my patient, not going to give me a laxative if my stomach is not working. You're not going to give me an anti-diarrhea if my stomach is not working. Maybe I have a bowel obstruction. Maybe I need a GI consult. They may need to open up to fix my bowel obstruction. Because you can give me as many laxative as you want. If I have bowel obstruction, it's not going anywhere. It's going to back up. I'm going to be in pain, miserable, and it's just a no. Bad things will happen for my patient. Heart block, CAD, debilitation. It's not a common, not common with these medications, but it's there. Adverse effect with these chemical stimulant laxatives. GI is diarrhea, abdominal cramping, nausea. Diarrhea because with these medications, you know, it's more of a trial system. Here's some laxative and you take it. Oh, shoot, that was too much. So now you have diarrhea. We don't really know your dose until you take it yourself. There's some standard dosage, but we still don't know. I might only require half a cup of of lactulose for it to work. It's patient dependent. CNS, headache, we don't see all these adverse effect as much. Oh, cathartic dependence. What does that mean? Elderlies, they are addicted to these things. Poop is life. They don't care about your stupid TV shows on Netflix. They don't talk about that. They don't care who won the Super Bowl. They don't care about the game. All they care about is they poop. Did you poop today, Johnny? Yes, I did. How about you? I had to work on it a little bit, but I had a little. But so they talk about poop, and most of the elderlies are dependent on laxatives so they can poop every day. Drug to drug interactions, it's so many to list. What do you need to know for these laxatives? Fecal impaction. Before you give somebody a laxative, do they have a fecal impaction? Do they have any type of obstruction? Are you having some abdominal pain? GI assessment. Put your stethoscope on their belly. If you're not hearing bowel sounds, I'm not going to give you some laxatives. Because if I'm not hearing bowel sounds, things might not be moving. Fecal impaction. If you have if you're impacted, I'm going to grab a nurse and say, and digitally disimpact you. Boop, 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 out, out, out. So now I can give you more. Now that you're disimpacted, you have this poop that's sitting in there. It's clear. Now I can give you some laxative for the rest of the poop to go. If you haven't done a fecal disimpaction, you should. If we're in a clinical setting, let me know if there's one, and I will let you do it. I'll watch from the door. Here's a few of the chemical stimulants: Sana, Dulcolax. Two of the most commonly used in the hospital. And I found this out. What did I say here? LA and Marissa, did you know castor oil is also used to grow eyelashes and eyebrows? I didn't know that. I just learned that when I was going through this, when I read the book. See, there's a lot of good stuff in the book. So now don't go to CVS now and buy up all the castor oil. At least I know where you will be when I can't find you in the clinical. Next is bulk stimulants. As I said before, it doesn't make it big. It just, it means they have the affinity for water, making them flow into the GI tract easier. These are mainly used for immobile patients, your patients on a vent, your patients that are stroke, bedridden patients. This is what they prefer. Contraindications for this, same as before. If they have GI issues, do not give them any type of laxative. Doesn't have to be bulk stimulant, laxatives, chemical laxatives. Do not give them anything. You might cause more issues for them. Adverse effect of bulk laxatives, same, diarrhea. If we give them, because we're not going to know if we give them too much, sweating, palpitation, flushing, it's the same as the other ones. Here are the bulk. I don't see one that's widely used in the hospitals. Next is osmotic laxatives. Draw more water into the GI tract and stimulate increased GI motility. Digital disimpaction, when you use your fingers to basically dig out the poop. Yes, yes, yes. We're gonna find one in the hospital, and so you guys can do it. It's a good experience. So let me know. I lost my mouse. So for the osmotic laxatives, I think we use a lot of these medications on the screen here, from mag sulfate, citrate, Melcomag, lactulose, Miralax, Go Lightly, Prepopic. Never heard of that one. But Go Lightly is the one we use to prepare our patient for endoscopy or colonoscopy. It comes in a gallon, and they have to drink that, all of it, to clear out their GI system, their stomach, so they can come in with a scope and see. Because it's difficult to scope somebody if they have poop or food in their stomach. It has to be clear. And they used to Go Lightly. Sometimes we give them 8 hours to finish this, or longer to finish this jug of laxatives. Boom, highlighted, bolded, lactulose. Lactulose for ammonia and liver disease. I forgot who it was. We had a patient. I think it was LA. We had a patient, liver patient, alcoholic, liver disease patient. He was jaundice, and I didn't see the lab of this guy, but typically, well, this patient was sitting up on a chair. He was awake and alert. Typically, when these patients come in, their ammonia levels are so high, dangerously high, at 120, 140, over 100, that they are zonked out. They're neurologically compromised. You may get a verbal response from them. More than likely, you will not. They may respond to your painful stimulus, but depending on how high this ammonia level is, they may not. So what do we do for those people? Try to fight you when they are 60 to 80. Oh, good one. So that means you should, I don't know if we can give ammonia, but if they can bring up their ammonia levels a little bit higher, over 100, they will not be fighting you. They will just lay there. But then again, when they come in with a dangerously high ammonia levels, we have to fix it. And this is the answer right there on the screen: lactulose. It's typically given Q6 hours, maybe even Q4 hours on these patients, because it's what brings the ammonia levels down. So what are we going to do? So on this confused patient or unresponsive patient, we're going to drop an NG tube, and then we're going to give them the lactulose every 6 hours through that NG tube. One side effect of that is I'm going to partner up with my BFF CNA, because we're going to be cleaning this patient up every couple of hours from the lactulose. They're going to be pooping the ammonia out. And after about a day or two, their ammonia level is going to start going down, and they're going to come around. And they're going to tell you, I'm sorry, Nurse Morgan, I was fighting you. I didn't know what I was doing. I was confused. It was the ammonia in my blood system because of my liver disease. They don't say it like that, but that's what they meant. So ammonia, lactulose is for my ammonia patients. One thing about this lactulose is it's sweet. I've never tasted it, but I've given it many, many times on a patient. When you open up the cup, it looks like that. It's like a thick syrup. Right? And it might affect their blood sugar. Not too much, but it will. Just so it's something we monitor closely. It's almost like a Benadryl or something. I know that's not been one of those thick sugary, like a maple syrup. Next, so Adverse effect of this, poop, a lot of poop, especially if we're using it for the ammonia levels, they just poop. And sometimes too, if the poop is liquidy, we will put what we call a flexi seal in them. It's kind of like a Foley catheter, but it's big. It goes up their anus, inflate the balloon, their liquid poop goes down into the collection bag. It's like a Foley for the poop. It goes into a poop bag. However, we can only use this flexi seal if their poop is liquid. If it's solid, then the solid poop is going to block the tube and nothing happens. Then we just gave our guy our patient a bowel obstruction. Not really, because as soon as we take it out, all that poop, solid poop, is going to come out. Not much here on the drug card. Next is lubricants. This is a different type of lubricant. These are poop lubricants. Docusate, Colace. You've given this. You've administered this on a patient. Has a detergent action on the surface of the intestinal bolus, making a softer stool. So when you're giving this to the patient, at least with my group, this is a stool softener. This is not a laxative. You guys know the terminology. Glycerin, sani soup, mineral oil. They make the GI tract slippery, all of these medications. And in some cases, especially with the Colace, a standard dose of this is 100 milligrams once a day. With the elderly, this is something they take as a maintenance medication. And when they're in the hospital, they're constipated because of the diet, the medicine, and whatever else reason, they might need something else. So it is not weird if they ask you for Nurse Morgan, can you also give me a milk mag with that? Because that's just, I haven't gone in a couple of days. And that is okay to do. They're not going to have diarrhea, explosive diarrhea, because you're giving them a Colace and a milk mag. Next, same. Nothing special here. They all work the same. They all have the same precautions. Not absorbed systemically. This is one of the beauty of this medications, though. Some of the others I mentioned earlier, it alters the sodium, potassium electrolytes of the patient. This one doesn't. They take it, lubricates the GI tract, they poop, done. Have a good day. Adverse effect, I don't know about that. I don't know about diarrhea, but the interaction is frequent use of mineral oil can interfere with the absorption of fat-soluble A, D, and K. I don't think I've ever had anybody have diarrhea from Colace. Others, Ilopan, Reglan, increases acetylcholine levels, stimulates parasympathetic. Now we're talking about controlling the poop from the brain. Metoclo, I can't pronounce, but I know how to pronounce Reglan. It blocks the dopamine receptors, makes the GI cells more sensitive to acetylcholine, leads to increased GI activity and rapid movement of food through the upper GI tract. This is the best friend, the Reglan is the best friend of your dietitian. Their job is to formulate the tube feeding for your patient that can't swallow. Maybe they're on a vent, maybe they had a stroke, whatever reason, they can't swallow, so they're gonna put them on some tube feeding. And sometimes the patient does not tolerate the tube feeding. Their stomach will not work with it. It's just going the Nepro or whatever tube feeding this is, it's going through their stomach. It goes in, they either poop it straight out, as in diarrhea, or when they're giving the patient through the tube feeding pump, when it's going inside the patient, let's say it's not going anywhere. It's just sitting in the stomach. How do you know that? Because when you're doing that, when you're giving somebody a tube feeding, you're also checking for residuals. Poop, I check my residuals. Oh, poop, this is a lot. So that means my patient is not digesting the food. They need something to help them increase the GI activity, and that answer is Reglan. So they will call the physician and say, Dr. Jones, this is Mike, the dietitian. My patient is not digesting the food. Their residual is over 300. Can we get some Reglan on board? Yes, you can. Get some Reglan in that patient, IV Q6, boom, and then their GI starts working slowly. Next is, still the stimulants. There's not much, this is the same as the other ones. Increases GI secretions and motility. Stimulants, it's almost the same. I should have just bulked all these together. But with this one though, with the Reglan, watch this, the drug interaction. Let's go with adverse effect. Generic intestinal spasms, cramping. I don't know about decreased blood pressure and heart rate, but we don't see that as much. It's there for a reason. I guess it happens rarely. But the drug interactions, digoxin, that's my heart medicine. You cannot mess with my heart medicine. Digoxin lowers my heart rate. If you start messing with my digoxin efficacy, then my heart rate might go back up, and so it's not going to work out. So I need something else. Cyclosporin and alcohol. I think that's why some of these medications have the warning in the box: do not take with alcohol. Nursing considerations, nothing here. It's about the same. As I said earlier, you do not need the pulse and blood pressure prior to administering this laxative. Maybe we should. Just because, or I mean GI stimulant. Reglan. If you look at this drug card here, Reglan can also be used for post-op nausea and vomiting. It is not the number one choice. The number one choice is coming up. It's not this one. So if I ask you about post-op nausea, vomiting, and you told me Reglan, it's the wrong answer. You can say, it says on the drug card, but I'm telling you right now, that's not what I want. I want the number one choice. I mean, I guess I have to word it. What is the best or number one choice? Types of antidiarrheal drugs. Pepto-Bismol. Where's my other one? There. Pepto-Bismol, what you see on the TV, it gives the stomach a coating. Folizac, I've never heard of this. As I said earlier with the previous class, mainly because we don't have much HIV or AIDS patients in our hospital, and at least in my hospital. So we rarely deal with these patients. Imodium, I'm very familiar with Imodium. I have a lot of them in my cabinet. And Paragoric, I'm not so sure about this one. This might be a new one. medication, but we don't use this in a hospital. It's mainly Imodium and Pepto-Bismol when we use in a hospital setting. Antiemetic agents. Throw up. This is the most common and most uncomfortable complaint from a patient. It just sucks. Sometimes it's worse than being in pain. There's a feeling of being nauseated and throwing up. I'm sure you guys have seen patients who fill up this green bag of just puke, 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 and you throw it away, hoping that they will feel better after they throw up. Some do, some don't. In some cases, it may be desirable to induce vomiting, just like when you're out drinking. You drink too much, you ate too much, you drank too much, that's coming up, you're sick. And you know, if you throw it up, you're gonna feel better. Those are in some cases. But for the most part, no, we try not to induce vomiting due to risk for aspirations. Many clinical conditions, the reflex reaction of vomiting is not beneficial. What does that mean? It sounds a little wordy. It means that I don't want my patient to vomit or be nauseated, especially my post-op patient. Because let's say I have a patient that had a brain surgery and now they're nauseated, let's say from anesthesia, and they're going, that means I'm increasing my patient's intracranial pressure, which is not desirable for them. I want my intracranial pressure to be low, especially after brain surgery. If I had a heart surgery, I have staples on my chest, and maybe that was done a couple of days ago. Staples on my chest, and now I'm going, not a pretty sight. My staples might pop. The sutures, staples inside my body, and maybe I had GI surgery. It might break because of this action. Because there's also an increase of at least pressure inside my body. So we don't want our patients to be nauseated in the hospital. Managing nausea and vomiting, emetics. These medications cause vomiting. Why do I need that? Because for a long time ago, it was required that you have an emetic in your cabinet, in your medicine cabinet at home, for in case your kid or somebody accidentally swallows rat poison, drinks Clorox bleach, or eats one of those Tide Pods. We want them to take this medicine, so they throw it up, they feel better, and you don't have to call 911, you don't have to call him, you don't have to take him in the hospital. That was, I don't even know how long ago, 30, 40 years ago. That was before my time frame, and my time frame is up there. So now, no, if your kid decides to eat a Tide Pod, call 911, take him to the hospital. We will deal with it from there. We don't want you causing, we don't want you stimulating or simulating vomit for your kid or husband, wife, whoever. Next is antiemetics. It's for nausea, vomiting. That's pretty straightforward. And these are the 5 different groups of antiemetic medications. Most of them you are familiar with. Let's start with the number 1. Phenothiazines, anti-anxiety drugs that block the responsiveness of the chemoreceptor trigger zone, so it decreases the nausea and vomiting sensations. Here's 3 of them. We don't use these as much in the hospital because I can't even pronounce them. there it is on the screen. Take a screenshot. So it works through the CNS system. It takes away that feeling of nausea and vomiting. Okay. Let's skip this. Not worry about this. This is what I want. The non-phenothiazines, prevention of nausea and vomiting, same. It works through the chemoreceptors in our brain. This is the Reglan. It's almost the same as all of the anti-nausea medications. One thing that they have in common is it may cause drowsiness, fatigue. I don't know about extra EPS and symptoms, but it's there. It happens rarely. So this is what I'm looking for. The number one drug we give our post-op PONV, post-op nausea and vomiting patients, is this one, Ondansetron. I can't pronounce that because I just know it as Zofran. And most of your patients in the hospital, this is on their PRN listing for nausea and vomiting. So I need to repeat that again. Zofran for post-op nausea and vomiting. I don't know what other clues you need from there. Next is the serotonin receptor blockers. It's not just for depressions and sleep. It can also be used for nausea and vomiting because it blocks the serotonin receptors in the GI tract. So it takes away that nausea and vomiting feeling. Here they are, Amend, Varubi. We don't use these as much, but they're there. They're available. I don't even know if these are available over the counter. Same indications, same contraindications, and as with the others, it just has a different chemical structure. It's the same. There's nothing different here. Interactions with this one, the most important thing is the Coumadin. We don't like it when it messes with our blood thinners, especially with the elderlies. There are a lot of them are on blood thinners from being on AFib, history of stroke, whatever else. We don't want it if it messes with blood thinners. Others, Marinol. I think the last time I saw Marinol was 20 plus years ago, but Jeff was telling me earlier he saw it in the hospital, wherever they're doing their clinicals, giving it to a patient. Because before we would use this Marinol to control the nausea, vomiting of cancer patients. It's in a pill form. It's this is pretty much marijuana, the pill version of the marijuana. And a long time ago, as you know, marijuana was not widely available, but now I can go down the street, get me as much marijuana as I want to control my nausea, vomiting. It's widely available. And so I don't need this anymore. I can get it as strong as I want. I can be high, I can be low, so there's no indications for this anymore. That's why we rarely see it. Vistaril, Tigan, not much used these days. Let's skip this. Now let's talk about anti-diarrhea drugs. There should only be one. At least I only use one, the Imodium. So with the previous medications, the laxative, they speed up the motility in the GI tract. With the anti-diarrheal, we want it to slow down so it doesn't churn my poop to the toilet. I want it slow. It's already going fast. I need it to slow down. Indications, diarrhea. That's it. Contraindications. I'm not going to talk about that. That's the generic. Here's if I have a history of GI obstruction, acute abdominal conditions, do not give me any GI medications. I need clearance from the GI physician that I can have GI medications. Because if I have GI obstruction and you gave me this antidiarrheal medications, you just made me more backed up. It's going to cause me more issues. Another one is it could cause your patient to go into this thing called toxic megacolon. Amongst all these others on the list, toxic megacolon is a life-threatening GI condition. You can probably Google that and look it up on YouTube, but I'm sure your med-surg instructor will be talking about this when you get to your GI section, because this is a big deal. Next, same with the interactions. There's so much you can interact with drugs, but I don't really think about that. If I have diarrhea, I just take the Imodium from my cabinet. Same there. Same there. That's it. So I talked about laxatives, antidiarrheal medication, some GERD, peptic ulcer prevention medications. And that's pretty much this section. And there's going to be about 15. There's more questions on this chapter than any other ones, because the other ones talks about cancer drugs, marijuana, alternative medications. I don't know the other ones, but this is the big one of the of all the for the finals. Questions? Nope. Good. That's all I got for today. Any questions? There is a question.
Is the final comprehensive?
The final, I don't see you, but I think that is Megan's voice. I'm gonna go with yes. I want to say 80–90% of it will be based on the new materials here and a sprinkle of the old stuff. I'll let you know what they are. So there's no I don't like surprises. No surprises. I'll tell you which ones. At least I'll direct you to the
Thank
chapter.
you.
Is that it? No questions? Nobody wants to go over their exam from my non-clinical groups? I mean, we can go over it, but it's not going to change anything. They've already gone over it. You've already gotten credits for whichever you think. All right, on that note, let us check out. I will see you Thursday, Friday.